through the definition. You have already gone through the definition of palliative care, so I'm not going through it again. So when we take the aspects of palliative care, we do the physical aspects does take an enormous amount of the care, but along with that, the psychosocial aspects plays uh, uh, a humongous role, more than the physical pain, more than the physical aspects. When we consider the psychosocial aspects, it takes about a humongous role. Okay, so what are these factors that we have to take upon? How is the assessment usually taken? So how we function at Pallium is that we work in a team. So we have our doctors, nurses, our social workers are there, physiotherapists are there, psychologists are there. Okay, so this assessment part is usually done by the social workers. So what they cover, what are the assessment criteria, what are the areas of assessment is what we will be covering today. And I have added a few small session on grief and bereavement because that is also important, which is not included in the syllabus otherwise or in the module otherwise. So I have added a few portion, I will be taking that in a very in a rushed manner, the grief and bereavement portion also, right? So, right. Why is psychosocial care important? Okay, I'll just start with an example. Okay, so you know our founder, Dr. Rajika Kurup, sir. So we have home visits and all, right? So he visited a home which happens to be near a coastal belt. Okay, and he visited the home, and the patient was having CA. Was a cancer patient, and he has two children and a wife. They live in a very small house, and he used to work as a fisherman. Okay, so he was in terrible pain. So immediately sir asked, like, you know how the pain assessment is done, right? So it's a pain score. The score a span of 1 to 10, and it's very subjective, and that's how we assess the score. And he immediately asked, so how much do you think is the pain? I mean, how much is the pain? So immediately he replied, the pain is like 10 by 10. Okay, so what is the immediate thing that we'll do? Please use the chat box, unmute yourselves. Right, what is the immediate thing that usually we take? Okay, a patient is reporting that he is having 10 on 10 by 10 pain, right? So immediately, yeah. Sorry, Raiza. Dr. Raiza, I think there's a problem with the volume. Please use the chat. You can also use the chat box. Dr. Raiza. So, okay, if a patient is reporting that he is on pain, and it's very good. Thank you so much, Dr. Upakul and Dr. Raiza. Right. So immediately what we did is that we started off with the pain management. Morphine was given, whatever the pain medication is, he was given all the medicines. And again, we know like it takes a couple of minutes to take its effect, right? So after a while, we again asked, okay, now how is the pain? And he again reported that the pain is 10 by 10, right? So he sat with him and asked, like, what the real concern is. And he said that, see, I have two daughters, and one is in 10th, and I think the elder one was in 12th. Okay, so I have two daughters, and he is the only breadwinner of the family. And if something happens to me, I know that the condition is very deteriorating. I know that the prognosis is bad. And if something happens to me, the whole family will come to a stop. My wife is not educated, or she is not working. And just like me, my daughters will also have to take up a job, that is, maybe they might have to become fisherwoman or something like that. And this was a big concern for him, and this was the cause of the pain that he had. So what we immediately did was that we found sponsors for the children's education. And it takes a few steps. So we prepared a story, and we found the sponsors, and we found a sponsor who would sponsor the children's education till graduation. Immediately the papers, everything was set, and we came back to the patient, and again, like, we submitted all the papers, and we promised that you just see that the children's education is being taken care of. They will anyway be educated till graduation. And now again we asked the pain score. And he said that he was not feeling anything at all. He was not feeling any pain at all. And that the pain score is 0 by 10. his only concern was his children's education, and that was what was causing his pain. Maybe the patient is literally might be having pain, but he was not feeling because he was relieved that his children's future was being taken care of. So this is where the psychosocial aspects come to play. The whatever the pain the patient is attributing to, or whatever the pain the patient is saying, it is not necessarily be physical. No matter how much pain medications we provide them, there might be other factors which might be contributing to the pain, right? So, living with a life limiting or life threatening illness, or the awareness of approaching that causes unique stresses and challenges, and this affects the quality of life of the patient. So, for this, to understand what other factors, what other stresses are there in this patient, we need to have a detailed psychosocial assessment, right? Can I have the next slide? Okay. Right. So I think you might be already been aware of the idea of total pain, right? The total pain is a combined compound of physical, psychological, spiritual, and socio-economic, right? So I'm not going again into the details of the total pain, how we are going to do the assessment. So the aim of the assessment is to identify problem areas which result from illness and may influence the well-being. So this requires a detailed assessment, and the assessment itself will take some amount of time. Okay, this is not something that we can do in 5 minutes or 10 minutes. This assessment itself might take some time, and usually the assessment is done by the social workers. And we need to collect information. We need to identify what are the strength of the patient, what support system is there for the patient, and where is the patient lacking it, at what level is the patient lacking in support. Right? And assessment and gathering of information is an ongoing process. See, one time the patient might have been the breadwinner, but the condition kind of the disease condition progress, and the patient condition is now deteriorating, and he is not able to work, and he is no longer the breadwinner, and we come to know that okay, he is not able to provide anything for the family. So this assessment process is going to be an ongoing process. We might have to take this assessment maybe every 6 months, or maybe every at least a year. We might need to do the assessment so that changes can be made. Right. So, inaccurate assessment will lead to our goal. Our goal might be we won't have appropriate goals if the assessment itself is wrong. So, we need to have a proper, complete assessment so that the goals that we set are also in align with the assessment or the needs of the patient. So, from where do we get this information? Basically, obviously, the primary informant would be the patient himself or herself, right? But along with that, we will gather information from whoever the caregiver is. It could be the spouse, it could be parents, it could be siblings, whoever it is. So, the other way we get the information is from the caregivers. And we might get information from friends, relatives as well, maybe neighbors. But no amount of assessment will complete if a home visit is not done properly, right? So assessment will be complete only after home visits. Only then we will come to know that okay, this home is like maybe situated deep, maybe on a hill, or maybe where the home is, the medical facilities are not nearby. Maybe they don't have very cooperative neighbors, or there are no other facilities nearby. So in order to have a complete idea of how they live, what are the support system they have, whether they have a roof on their head, whether it's leaking, whether they have a proper house to live in, whether they have a proper support system from their surroundings, we might need to do a home visit. So a home visit, a full assessment can only happen in the home care settings when you visit the home, right? So the areas of assessment include patient and family overview. Am I going a bit too fast? Or is the space okay? Please comment in the chat box. Please use the chat box so that I'll know, and I'll make the changes accordingly, right? Okay, thank you. Okay, thank you. Thank you so much, Dr. Kurup. Right. So we might need to assess the patient and family overview, like who are there. The basic demographic details will be covered up in the patient and family overview. Inside, whether the patient and the caregivers or the family members are aware of the diagnosis as well as the prognosis of the disease condition. Family structure and dynamics. So who are the friends in this? Who is the decision maker? How does the family dynamics work? Who are close within the family? Do they have any support from around? Socioeconomics as well, whether they are living in a poor socioeconomic status or whether they are average socioeconomic status. Environmental assessment, whether they have hospital facilities, vehicle facilities nearby, whether they have public health PHS nearby, whether they get a required amount of support from the neighborhood. So these assessment will come under environmental assessment. We have psychological distress, whether they have any psychological distress like depression, anxiety, whether they have any suicidal ideations or any attempts that has been made in the past. So these areas will come under psychological distress. I'll be explaining each of these sectors in detail, okay? And then spiritual impact of the illness. So what we see in our patients, especially patients with life-limiting illness, is that they have some amount of spiritual distress, right? It is not necessary that spiritual illness has to be religious, okay? Sudden change in belief system, okay, that is also included. But more than that, here, when it comes to a life-limiting illness and the spiritual impact of the disease, most of the time a loss of purpose. There is no purpose in life, there is absolutely no meaning in life. The patient kind of completely loses that something that connects them with holding on and all. So all these aspects, complete hopelessness, all these aspects come under spiritual impact of illness, right? And then interventions and plan. What can be done? Whether physical management, whether curative aspect is possible. Maybe social workers might have to involve, whether they are getting all these government schemes or any pensions, if at all they want. All these can be facilitated. If at all there is a psychological need, but if at all there is a counseling need, maybe we might have to call upon people of that expertise, and maybe we might have to do interventions as per need, right? And how we go about this will be covered, right? So the first criteria is patient and family overview. What comes under patient and family overview is, as I mentioned, the basic demographic details. What was the occupation that the patient had before the illness and what is the condition right now? Maybe the patient might have been the breadwinner of the family, but now because of the disease condition, he or she is not able to work. So there is no income in the family. So all these details will come under that. Primary caregiver. So who is taking care of this patient? Is it a spouse or is it the parents? Who is taking care of it and what is the relation? And then the next category is insight. Whether the patient has any idea of his or her diagnosis. Most of the time, what we see is that the patient knows that the patient is having cancer, but he does not know the severity of the cancer that the patient is having, right? For example, the patient may not be aware that he is in stage 4 and that his condition is deteriorating. He may not have any idea related to that. So whether the patient is aware of the diagnosis, whether the patient is aware of the prognosis, and whether the patient has any idea of what palliative care is, and whether the family members are also aware of the prognosis diagnosis. Most of the time we also see for a fact that the family members may not be ready to share that the patient is diagnosed with cancer. Most of the time we also see that they are not willing to say the diagnosis itself. They are not willing to reveal the diagnosis itself to the patient. So we might need to assess all these areas while doing the primary assessment. Next is family structure and dynamics, right? You might be very much aware of the genogram, right? The family tree that we usually draw to pictorially represent the family dynamics, right? Right. So that is what comes under the family structure and dynamics, and we might need a complete genogram, family dynamics, to see that who are supporting, if there is any conflict at all. And again, and then what comes under family structure is that history of the illness in the family, whether there is any genetic factors that are linked to the disease. So all those things will come under family structure. So we'll now see genogram in details. So genogram, as you know, is an idea which was put forward by Murray Bowen. It is a graphical representation of person's family over at least 3 generations. Okay, we at least say we need to draw at least 3 generations, right? Which tells us about the structure, dynamics, strengths, resources. Types of information usually added is name, age, educational, occupational profile, and emotional relationship. Right? Next. You might be aware of this. The male is usually shown in squares and the female in circles. And if they are married, we show with a single line. A question is coming up, right? So I hope you will pay attention to this two slides that are following. And if they are living separately, we usually draw a slash over the line. And if they are divorced, we usually draw two slashes. And if the child is adopted, a single line and dotted line. And if the child is a foster child, dotted lines. If the patient is pregnant, we usually use a triangle. Stillbirth, a square and a cross. And if it is twins, two circles, whether it is a female or male child, according to that, it would be coming from a single branch, right? Next. Right. If the relationship that they are having is a very normal relationship, it is a plain line. Okay. And if what the relationship they are having very close, for example, they are like very close to the sibling or very close to the where they are like very close, we usually use two dotted lines. And if they are like very close, I mean very intimately close, then we use two double lines, straight double lines, right? And if the relationship between the people are a bit hostile, they are in conflict, they have on and off arguments, then it is usually shown in zigzag lines. And if there is any physical violence involved, we usually use zigzag lines, but the frequency has increased, right? And if there is emotional abuse means here maybe the patient or the whoever is the person might be afraid to say, there might be fear factors, there might be verbal abusers involved, right? Then we use a blue zigzag line. And if there is sexual abuse involved, we use two zigzag lines, double zigzag lines. And there is neglect. Neglect means we usually hear stories where the grandchildren, I mean the grandparents are left alone in a room without being looked after in an unhygienic conditions. Maybe there is maggots around them, right? Maggots, or maybe they are being eaten up by worms. Complete neglect is that we usually use dotted lines with the arrow mark, right? I hope this slide is okay, and I'll just spend a minute or so here, right? So because a question is coming up. Any doubt in this area? Right. So we'll move on to the next slide. So I need one volunteer from our participants who would like to say like what they make out of this slide. You can use a chat box as well, right? Any one person who would like to make comment on this. This is a usual slide that we usually see in hospital settings. Okay, usual family tree that we usually see in hospital settings. Anyone? Come on, doctors. I know that it could be a very busy schedule that you are having. Maybe you are in OP or IP and all, but those who are free at least, maybe you can just unmute yourself and say whatever whatever information you are gathering from this slide.
Yeah, so Dr. Rosa is saying this is genogram.
Right. Normal relation. Okay. So who is the patient here?
Okay, I'll attempt. Patient is 60-year-old female whose name is Leela. She is a homemaker. She is married to Mohan, who is no more now. So she has a daughter by name Sindhu, and I don't know what the lines indicate. Who's 40 years old. So can you help me out with that?
Yeah,
40-year-old
actually
Sindhu.
Sindhu is our patient, and we usually represent in shaded form. Okay, the patient is
Okay,
Sindhu.
okay. The shaded is the patient. All
Yes.
right. Okay, so the patient is 40-year-old female Sindhu who is married to Raju
Okay.
and also married to another person, Saji, who is 45. So
Right.
Raju is no more now. So with Raju, she has a son who is in 11th standards, whose name is Saran, who is 16-year-old. And now she's married to Saji, with whom she has twins who are 13 years old, Amal and Vimal.
Thank you so much, Dr. Kalyani Pai. Thank
Yeah.
you so much for what. So we get to know about a basic information from the slide, right? Now we'll move on to the next slide. Right, the same family structure, but we can gather a lot more information from the slide, right? So anyone up on this? Anyone up for this to explain the slide? Dr. Uruza, please. Who is willing to give it a try?
Yes, ma'am.
Yes. Are you willing to give it a try?
Yes, ma'am.
Sure, please. Right.
Basically,
Huh.
Cindy is our patient, and the bold lines show the good relationship. Like we have green lines.
Right.
Sindhu's good relationship with Indra, in Sindhu, Bindu, and Cedar, seventh standard, the child. And Saji is not having good relationship with Sindhu's, Sindhu's son, I guess, Sarath.
Right.
It's like the zigzag line shows bad relationship, and the bold line shows good relationship. And
Yes.
what we're having is it's like, and Sindhu's life is like, the primary cycle is surrounded. It's like you have given a circle around Sindhu and like
Right.
Sindhu's children and the Saji main primary family which is there. So it's like that. And since Saji is having twins, and Amal and Vimal, and also there Saji is not having good relationships with Subhash and
Right.
Veena.
Right.
Yeah.
Thank you so much,
Yeah,
Dr. Uruza. Yeah, please go on.
thank you.
Thank you. Thank you so much. So we can
And
clearly, you want to say something
basically,
more? Sure.
basically, I have learned this. I have done a postgraduate diploma in family medicine, CMC Bangalore, and this I got it. This was a vast thing, but and whenever I write a patient history or something like that, like I used to fill up. There is like we have one page, and on that we need to show like family of a patient. So I just give this genogram because it just makes my work
Definitely,
very much
definitely.
easier. Yeah, it
Right.
makes my work easier.
Because,
And it's like,
right.
yeah, holistically, I have to take our patients. So it's like, it comes in that, like relationships of a patient with like family members, ties, how the ties are going, like that.
Right. Thank you so much, Uru. So as she mentioned, see, we get a lot of, instead of reading a lot, instead of writing a lot, this picture itself will represent a lot about the family dynamics. Thank you so much, Dr. Raiza, who I like use the chat box. Thank you so much, Shruti Bhagat. Vimal is a close friend. I'll just summarize what Dr. Uruza just mentioned. So Sindhu is having a very close relationship with her siblings, that her two sisters, and she is very close with her first child, that is Sharat. And as Dr. Uruza mentioned, the stepson and the stepmother. Sorry, Dr. Uruza, please mute your. Yeah, I think. Right. So the Shaji is not having a very good. The stepson and the stepfather, they are not having a very good relationship, and Shaji is like very hostile towards the first child. But at least the sibling, the children, they have a very close relationship. That is Bimal and Sharat. And Shaji is also having a hostile relationship with his siblings. Maybe there is some character issues with Shaji that we might need to assess in the coming session. So, and the circle shows whoever is living under one roof. Okay, whoever is living together is usually shown inside a circle, right? So, Shaji, Sindhu, and the children, they live together and they are living under one roof. So, and this representation, we may not be able to get it in the first go or the first assessment. We might we might be able to grow this pictorial representation. Maybe it might take multiple sessions to come up with more information. Maybe in the next session, I might be able to come up with more information, right? So, with each sessions, we will be able to grow this, right? So the next is the environmental assessment. What we focus here is that whether they have their own home, whether they are in a rented home, or whether their home that they are living in might need some repair. For example, it is overflowing with water, or there is water dripping down inside the home, and there is no proper ventilation or something like that. So if at all there is any need in the change in the environment, we need to assess position of the patient in the position of the patient in the house, whether it is very crowded and cramped, but if there is no proper light, and most of the time we see that they are like if a patient is completely bedbound, they are just left there without any light, unhygienically they might be left in a place, right? So we might need to take the patient, make sure that the patient has proper ventilation, there is proper lighting inside the house. So all this assessment will take place only when we do the home visit. and a kitchen, whether there is open food storage, whether there is a proper disposal system is there, and water supply, whether there is any issues with water supply, and whether they have access to main road, hospital. So all our patients that are registered under Pallium, when we go to their home, we can see that they are in hilly areas, and if the patient is traumatic paraplegic or a quadriparalysis patient, it is very difficult to shift the patient for a catheter change. It is very difficult to do the catheter change every month, right? So home visits might be need, a home care might be needed, where our team visits along with the doctor and the nurse to do the changes like catheter change or a Riles tube change, and also all this has to be taken into consideration while we do the assessment part. And then comes the echo map. This idea was put forth by Anne Hartman. This pictorially represents what support system that the patient is having from the society. Right, a pictorial representation of patient's family in its social environment relationship with the larger society. A snapshot view of the importance interaction of the patient family with other system groups, whether they get supports from any religious institutions, maybe if they get any supports from a church, or whether they are getting support from any other NGOs, whether they are getting availing all the government schemes that they have. So all this will come under echo map. Right, so the volunteers, health services, neighbors, workplace, government services that are there, community services, how they are with their neighbors, if at all the school is providing something, if the volunteers are supportive enough, all this will come under the echo map. Whether they have a hostile relationship with them, whether they have a very friendly relationship with them, all this will be represented in the echo map. I'll just show a picture of a family unit, right? So this is a family unit. The patient is female. So we can see that the husband, the patient, and the children, they are living together. They have a very good rapport with the church, the college, and the youth organization. The church people they might be financially aiding them. Maybe they are giving food kit or something like that. The college of the sons, the college, we do all these fundraising things and all, right, in colleges and all. So maybe they are getting some kind of help from the college, the sons college. They have a very hostile relationship with the neighbors. Maybe we have seen this in the case of COVID as well. When during the COVID time, they were like the neighbors were like completely hostile towards a patient who is affected with COVID. They won't help. They're thinking that this might spread, and people still have a stigma that cancer might spread. And again, not just cancer. It could be a TB patient, and they have all this stigma and taboo around them, and they completely turn hostile towards the patient and the family, right? So the neighbors are showing a hostile relationship with the patient and the family, but they are getting support from other NGOs and the volunteer and self-help groups, etc., right? So this echo map literally shows what support system they are getting from the environment, from the society. Maybe it could be a religious group, it could be a charity, it could be an NGO, it could be anything, right? Right. Then we come to the spiritual assessment. So as I mentioned in earlier, spiritual assessment is not just the religious aspect of it. Okay. Obviously, religious issues might come up. So we have had patient with CA, neuroendocrine, and we usually see a shift in belief system towards end of life. Okay. I could be a Hindu, and when I reach end of life, maybe my condition is deteriorating, and I'm in stage 4, my health condition is deteriorating, and my days are counting. There might be a sudden shift in the belief system. Like I suddenly start believing in Jesus, right? We usually see this in our patient. There could be a change in the belief system that the patient is having. Suddenly, I believe that, okay, maybe Jesus could help me. I have lost faith in my religion and my faith, and now I'll take up faith in some other religion. This usually is done as cry for help. Maybe there might be some way out of this disease. Okay, people do this. Maybe they are too desperate. There could be multiple reasons for the change in belief system. It could be their only hope mostly, right? Okay, so we see a change in belief system. We see a change in religious aspect. But it is not just the religious aspect that comes under the spiritual assessment. It could be connection. What gives me purpose in life? What gives me meaning to my life? What is one thing that gives me happiness right now? It could be my grandchildren's spaces. It could be It could be a simple hello from my friend. It could be just the presence of my husband. It could be anything, and this will work as a spiritual thing. This could work as something to hope for tomorrow, right? And if a patient is lacking all these things, we might say that this person is having spiritual distress, and we have like spiritual distress tool and all to find out and assess, right? So connection, who are the persons or communities you look to support for? Who are there with me? What gives meaning to my life? Do I believe in a power higher than a greater than myself, right? Has your life situation now affected your feelings about yourself, your faith or relationship? Meaning and joy, what has been most important in your life? What are you most thankful for? What makes or had made you happy? Is it could be simple as that, maybe watering a plant. It could be the garden that I had in my home that I used to look after. It could be anything. It could be a simple smile of your grandchildren. It could be that to any other thing, right? So what do you feel the proudest in your life? It could be my work. It could be my work, the amount of effort that I have put in my work. Strength and comfort, is there anything that is comforting to you now? Does something give you comfort to you right now? What helped you get through difficult times in the past? Will that help right now? So all these concerns, is there any hope for, or is there anything that you hope for? Is there anything that feels unfinished? So if you have spoken to people who has advanced cancer or any other advanced life limiting illness, we see that they don't have any hope. They feel like, okay, everything is going to come to an end. I don't have anything to hope for. I know that my life is done. So what's the purpose of living? I don't have anything to hold on to. It could be better if I die. Maybe I'll just commit suicide and all the pain and everything will come to a stop, right? So all these will come under spiritual issues. For example, I'll just share a story. We have a patient. We still have him. He was 18 years old. When he was 18 years old, he went out with his friends to celebrate, and he was playing around the river, and he did a somersault. Okay, and instead of falling into the river, he like fell on the shore. I mean the shore side, and there was spinal cord injury happened, and he was diagnosed with quadriplegia. And what followed was that, what happens in quadriplegia, right? A complete limbs, all the four limbs, he's completely bedbound. He cannot use any limbs from the neck area, from the chest area till his toes, everything is paralyzed. He is not able to get any sensation out of it. So he has been like that. Now he's 22, 23, I think. He has been our patient for the past 5 years. His father is an alcoholic. His brother is a drug addict. Her elder brother is a drug addict. He has a sister, but she's married off and she's having her own family. So the only person who looks after him is his mother. Okay. So there are certain things that we take for granted. Okay. If I want to move my hand, I can just simply move, right? If there is a fly on his face, he has to wait for somebody to just fly it away. And if he wants to at least drink something, he needs help of the caregiver, whoever it is, right? So the amount of pain that he is going through, it's more than what we can even imagine. And every time I go to him for a session, for a counseling session, he has been requesting for euthanasia or mercy killing. And as you know, it is not legal in India, right? So we try to rationalize with him. We try that it is not legal in India. So the next question he is asking is that, see, he's very young and he's well built and all. He's a very young looking, good looking chap. So the next question he's asking, he calls me Chichi, okay, Didi or whatever that is. Right? Yeah, he calls me Chichi. Chichi, see, I'm going to remain in this condition till I'm 60 or 70. Right? See, as I don't have any other comorbidities or anything like that. See, I'm going to continue in this situation till I'm 60 or 70. So, what's the purpose of me being lying just like this without being any use to anyone, and I'm becoming a burden to my mom also? It's better I'll just die. Why people are not allowing me to die? He has high suicidal ideation, and we actually had a psychiatrist on board to assess his, and we started off with antidepressants and on. And we have diagnosed him with major depressive disorder. So he's right now under medication, but the suicidal ideation, everything is there because his condition, there is nothing for him to hope for. There is no purpose in him. He feels that there is no use living like this. And he has been trying to convince his mother also, we'll just commit suicide together, because his physical disability will not allow him to even commit suicide. If he was even at least able to move his hand, he would have committed suicide. That's his condition, right? So these factors, more than the physical pain, there are all these factors that affect a patient, right? Next slide. So what are the interventions that we use? Psychoeducation for the family as well as the patient. We might need to have a long conversation with him about his prognosis, the diagnosis, what can be done, what cannot be done. All those factors will be involved. Providing proper information, yes, and what other support groups can be found, facilitation for other consultation or anything. If at all rehabilitation is possible, what can be done? So for this patient, we found a sponsor who actually gave a hoist so that the burden on the caregiver, that is the mother, is reduced. Every time the mother, he actually baths once in a week, okay? And his mother on the day of the bath will stand outside the house and will be like looking for whoever is passing by, she will be like looking forward for that, so that he can be shifted to a wheelchair so that he can be bathed, right? But recently we found a sponsor who gave us a hoist, which is easy to transfer him from the hospital bed to a wheelchair. And we are trying to find other ways in which he'll feel worthy of. So in between, we found a job, a tele center. He actually speaks very well. Okay, he is very fluent and he speaks very well. And we try to connect with companies who would provide him like telemarketing kind of work, right? So that even if it's a very minimal wage that he is getting, he'll feel worthy of, he'll feel valued for, he'll feel something to, he'll feel that purpose is getting coming back to him, right? So rehabilitation, it could be vocational rehabilitation, it could be PMR, it could be physical medical rehabilitation, bereavement support, if at all that has happened, what other things can be done after the death can be done in the bereavement support thing, follow-up and supportive counseling. Right. So I think you might have heard this in the previous sessions. We never say bystanders. We usually use the word caregiver. Because bystander in a literal sense will mean that only a person who is just standing beside, right? A person who is standing without doing anything. But when it comes to the caregivers of our life patients of life limiting illness, the burden, the care that they are giving is something that has to be valued and respected for. So there are only 4 kinds of people. This is a quote by Rosalind Carter. So there are only 4 kinds of people: those who have been caregivers at some point in your life, those who are currently right now are in the caregiver position, or those who will be caregivers. Maybe in the future we might have to be a caregiver. Maybe we might have to take care of our husband, our spouses, or our parents or someone, right? And the 4th person is those who will need a caregiver. Maybe we'll reach a position where we might need a caregiver, right? So always respect those individuals, always respect the caregivers, acknowledge their complex role. It is not easy. For example, take this patient for the patient that I have mentioned. The mother has been looking after him for 4 to 5 continuous years, and she is having physical ailments and aging issues and all, but she keeps shifting him. It is not easy shifting a 5 feet 6 inches tall a young chap. You know how tedious it could be, and she is the only breadwinner. She cannot depend on her husband because he is an alcoholic and the elder brother is a drug addict. So the amount of vulnerability that the caregiver is going through is also more. So we need to acknowledge that. Never dehumanize them by calling bystander. So we usually use the word caregiver. Right. So we'll just go through the slide. We have a case study here. A 56 years old lady, Mrs. A, has been diagnosed with CA breast in 2016. She had undergone mastectomy, that is breast removal surgery, was referred for pain management. She looked very anxious and had no idea of what palliative care is. The other comorbidities that she is having is she is diabetic since 12 years. She has CAD, fracture on leg due to fall in 2019. She is a widow, and her children are having a hostile relationship with her. So she lives alone in a rented house. Now, I need my participants, whoever it is, the 50 participants, at least one or few of you, to explain the total pain that this patient might be having. For example, what are the physical disability, what are the physical difficulties that the patient is having, the psychological, the socio-economic issues, and the spiritual issues. Right. Do you want me to display the other slide? A few S's in the chat box would be very helpful. Or okay.
What's the financial status?
See, we have only this much information as of now. She's living in a rented house. Okay, so it gives a very idea that she's not having a home of her own. Maybe the financial status would be very poor. Right. So, what are the physical? A lady, 56-year-old. What are the physical conditions that she is going through? What are the physical issues that she is going through? You can use a chat box or unmute yourself.
Under all the four domains, so
Right.
Rajika wants you to type your answers under physical, under emotional, so psychosocial as well as social. So, okay, for physical, Dr. Rosa is mentioning pain, okay.
Pain.
Apart from that,
Pain, immobility. Thank you so much, Dr. Kalyani.
So Dr. Rosa is saying emotional
Deformity. It's yeah. Thank you. Anxiety, depression. Thank you, Ravindra. Thank you, Lorna Fernandez. Pain. Deformity. Can you please be specific? Is it she lives alone? Emotionally, she is distressed. Thank you so much, Dr. Rosa. Again. Thank you, Aditi. Pain. Right.
She's living alone, so the loneliness itself must be giving her more pain.
Thank you so much, Shilpa. Dr. Shilpa, thank you. Physical fracture, very good. There is this physical disability is there because of the fracture, right? Not able to walk. Thank you. Mastectomy, physical insecurity, that is usually called as body image issues. Thank you so much for putting that up, Dr. Kalyani. Dr. Upakul, thank you. Psychological living alone. Thank you. Financial problems. Obviously, she has to have a lot of financial trouble might be there as she's living alone. She's a widow and her children are not supporting, right? Okay, so we shall move. I'll just put all these together, right? I think most of it are covered. Anyone else want to? Thank you, Dr. Abhishek Kumar. Pain, application, angina might be there, right? Yeah, someone was speaking, sorry.
Hormonal imbalance.
Imbalance we might be there. Thank you, Dr. Raiza. Right. So we'll just look at a few issues. Physical, these are just some of them. We have not covered everything under this. Diabetic neuropathy, retinopathy, thank you so much. So physical pain is one thing and the patient has been taking chemotherapy, all those things, surgery is done. So the medication will be there, fatigue is there, lack of sleep will be there, difficulty in walking might be there because of the fracture as already has mentioned. And then there might be body image issue. I think that also has been mentioned in the chat box by some of the doctors have mentioned that. So there might be, see, being a woman at 56 years old and being having gone through mastectomy, it is not easy to face the world, right? There might be a lot of body image issues, a lot of insecurities that might be there, right? On psychological perspective, isolation, loneliness, she's living alone, the children are not supporting, they are like having a complete hostile relationship with the mother. So that could be a reason for pain. Emotionally, she is weak. Anxiety about future, that was already mentioned in the slide, right? She was anxious. She does not know what has to be done. Unclear about her prognosis, and she has no idea of what palliative care is. Distress due to multiple illness. She has CAD. She has been diabetic since 12 years. She has a leg fracture. So all these will contribute to the pain that she is having. On spiritual level, why all this suffering? Obviously, she might have lost faith. This is not evidently mentioned in the slide, but she might have lost hope. She does not have any significant person in life. The children are not supportive. The husband passed away, so she does not have anybody to hold on to. She does not have any significant person in her life. No memorable joyful events, loss of connection with family. All this will affect in the spiritual domain, right? And when it comes to socio-economic level, strained relationship with family. As I mentioned, the children are not supportive, unable to go for a job because of the physical disability, and she is a widow and she is not getting any other financial support. Unable financial instability, house is rent, she does not have a house of her own, she is living in rent. Again, that will add up on the financial burden. Low accessibility to hospital, absence of a caregiver and support system. That is very important. See, she does not have anybody to look out for. Like she is bereft of having a caregiver or a support system, right? And all this will contribute to the pain that she is going through, right? It won't just be the physical pain. It could be a compounded effect of all these aspects. Thank you so much who has responded. Thank you. Right. So, who are the vulnerable population? Those patients who live alone, elderly without support, single parents, multiple patients in family, victims of gender issue, domestic violence, etc. Individuals with mental health issues, individuals with suicide ideation, socially isolated people, for example, TB patient, etc. Substance users in family. Also, all these people are vulnerable, and the risk factors will be more for these people, right? So those are living alone, those who have like some kind of mental health issues. So all these people will be on higher vulnerability or higher risk of having pain or high other issues. So what is dignity? If I ask you to define dignity, how will you define dignity? Any doctors, please. What is dignity? What does dignity mean to you personally?
Yes, that you can post in the chat box.
What do you think is dignity for you? Yes.
A person does not have to bend down in front of somebody else for help.
Okay. Okay, thank you, Dr. Shilpa. Respect for sir. Thank you, Ravindra, Dr. Kalyani. So when it comes to dignity, it's like defining when you define, if I ask you to define love, if I ask you to define hate, it's very subjective, right? For all the 49 people who are sitting in the session will be having different definitions, right? It's very subjective. And for each person, similar to love and hate, the meaning of dignity will be different. And to assess dignity, we might have to personally have a conversation with the person, a significant person, to know what he or she feels is having dignity. See, I am an independent woman. Okay, say I'm senior psychologist with Pallium India. I have been working. I'm the breadwinner of my family. I am the decision maker of my family, and I have been. I drive myself to my workplace. I go back I go back on my own. So I'm independent. I'm taking care of myself. Suddenly, people are saying that okay, you are having lungs or something, some sort of CA, and you are in stage 4. You might have to and suddenly my health condition deteriorates, and suddenly I am diapers. Okay. For a person who has lived his or her life till 54, 56 years, completely independent, looking after himself or herself, being on diapers, being bedbound is not easy. It's a big cause for loss of dignity in people. See, we might have to put ourselves in their position. See, there was this patient, there was this Amma who was admitted in our IP, who needed help from her son to for the bowel movements and for passing urine and all. And we found that she was not having a proper the bowel movement, everything was irregular. So, and all other things are normal. So I was called upon. I had a session with the mother, and I asked Amma, see what's Amma, what is troubling you, and how are things, and also, what she said, it's my son who is with me, and it is very difficult for me to do to pass bowels or to pass urine in front of him. This affects me a lot. If it was my daughter, if it was a female, or if it was a lady, I wouldn't have bothered. But it is my son, and it affects me. This was a big trouble for mother. Right? So for that Amma, for that mother, the fact that she had to strip in front of her son, she has to do the bowel movements in front of her son was a big cause of concern. Right? So, and there was this another Amma who was admitted in our IP. She had a fall. She was a paraplegic patient. So she was wheelchair bound. So she has bed sores and for this admission, the bed sore was in the sacral area. So while I was having a session with her, she mentioned that, see, the only thing that I prayed for is that, see, I will manage bed sores if at all it is coming in any other part, but I only pray to God that it won't come in the sacral area so that my son won't have to do it. And it is very difficult to do the sacral part dressing on my own. And this affects her a lot. And you know what? She doesn't allow her son to dress that sacral wound. She uses a mirror to do that. See, she is finding ways so that she won't burden the son, or the son won't have to see the sacral bed sore, right? So this is dignity. So it is very subjective, and most of the time, what happens when a patient is admitted to a ward? See, my name is Rajika Kurup and I'm a senior psychologist. Everything, all these things vanishes, right? And I'm a mere, okay, sister, please go and see this patient who is in room number 4, ward number 4, bed number 3. My name, everything becomes insignificant there, right? Insignificant there, right? I'll be a mere file number. I'll be a mere bed number. Okay, visit this patient in ward number 5, bed number 4, all these things, my name, my work, everything becomes insignificant, irrelevant there. So acknowledge always when you are talking to a patient, just make sure that we give the respect that the patient deserves, no matter what the patient is going through, right? So in the inability to acknowledge person, the insensitivity of not acknowledging personhood or individuality could be psychologically devastating. So always respect. And always, whenever you're talking, please make sure that you respect them for whatever they are, right? People experience a loss of dignity, have significant higher rates of depression, anxiety, and feeling of hopelessness, right? So make sure that our attitude, this is the ABCD of dignity conserving therapy. Our attitude is when we are kind, our behavior, the behavior that we are in align with our attitude. Make sure that we're compassionate towards our patient, we care for them. The way we communicate should always also be in a very dignified manner. Right. So these are some certain things that we do beyond the curative aspects, beyond the physical management. That is, we try to celebrate birthdays, anniversaries within our IP, if at all the days are in congruence. We try to occasionally rehabilitate patients or the breadwinners or the caregivers if at all the patient has passed away, and we might need to rehabilitate the wife or the husband, whatever it is. The paraplegic, the patient, you can see a few occasional rehabilitation that we have given. Farming is one thing, animal farming is one thing. Umbrella making is another thing, stitching, anything, whatever is possible from their point of view, whatever they are capable of doing, we try to occasionally rehabilitate. And education support for children is another thing that we focus on. We try to find sponsors to educate the children, right? For this, again, we need a great amount of volunteer support and support from the society, right? Any doubt till now, psychosocial aspects? Okay, we'll move on to grief and bereavement. Okay, it's a very big, huge topic, but I'm trying to take a brief amount of it, right? So grief and bereavement. So what is grief? What is grief? I do acknowledge that we have limited time, so I'll just rush through the topic. What is grief? What do you think is grief? Grief? Anyone? Grief? What is grief? Has anyone gone through grief? Emotion? Thank you, Dr. Ravindra. So thank you, Dr. Somadatta. Loss of someone, some loved one. Sorrow. Thank you, Dr. Upakul. So grief is anything that an emotion that we feel immediately after a loss. Period of sadness. Thank you, Dr. Kalyani. So this loss has happened, right? And the emotion that we go through after the loss has happened is called as grief. And it could be a loss of a loved one. Is it just loss of a loved one? Is there any other grief that comes upon? Okay, for a fact, we can know that a person dying, a loss of a person is grief. Is it that the only thing that will come, that we'll have grief upon? No breakups, no relationship issues. Nothing from our participants. Anticipating loss. Thank you, Dr. Ravindra. Any other loss?
Body parts.
Thank you so much, Dr. Raiza. Definitely loss of body parts doing amputation.
Any sorrow which disturbs your normal being.
Thank you so much, Shilpa. Thank you, Dr. Shilpa. So it's not just a loss of a person. It could be anything. We'll be coming to that, right? So, and if there is a loss of a person, if death has happened, right? If death has happened, there are certain rituals that take upon, right? For example, in Hindu religion, we have a ritual that takes place after 5 days, and we have a ritual that takes place after 16 days. And all these rituals, to an extent, will help us to cope with the grief, cope with the loss that has happened, right? And there is this custom in Nepal where the son has to isolate himself from all the other families. And there is this other ritual that is there in Nepal, which is that the grieving family, the bereaved family, does not have to cook for themselves for a week or so, and all the other members will help them. So all these rituals in some way will help us to cope with the loss. See, I just lost someone. Okay, I just lost my dad. I don't want to immediately cook for people. I don't feel like cooking for anyone, right? So all these rituals, I don't feel like talking to anyone at all, right? So all these rituals, to an extent, help us to come up, to cope with the grief, to cope with the loss that has happened, right? So what are the kind of losses that we have? It could be identity and customary roles. See, I was the breadwinner. I was the breadwinner. Hold on, video. I was the breadwinner. I am the breadwinner. So my name is Rajika. I am a psychologist. And all these things will come to a halt when I am being said that, okay, you have been diagnosed with stage 4 cancer. So how am I going to perceive this information? See, all those factors, all my identity, everything comes to a stop, right? See, immediately I have a different thing that my physical functions, as somebody has said, a loss of physical issues, somebody said, right? Somebody mentioned in the chat box. See, amputations. As I mentioned in this child's case, the child being a quadriparesis patient, the amputation, not being able to not being able to be independent. Relationships, see, how does losses affect relationship? How does relationship come to a loss? There's this research study which says that 40% of women with cervical cancer are being abandoned by their husbands. This is one way in which we lose a relationship when it comes to life limiting illness. If at all this loss has happened, maybe I'm going through I'm having a life limiting illness, I'm having stage 4 cancer, I won't feel like talking to anyone, I won't feel like talking to my friends, I'll self isolate. So that is one way in which we kind of hinder our relationship, in which we stop our relationship from going ahead. Material and economic losses. See, my entire savings will be now spent on this treatment, on this surgery. So there is economic loss that is going to happen. Time, my entire time is going to be shifting from my hospital to my workplace, from hospital to my home, and I don't have time for myself, I don't have time for my family. All my time is spent for some blood investigation, from some scanning or something like that. Opportunities, maybe I was about to be a head of the department, maybe I was about to go abroad. All this will come to a stop, right? My plans, my autonomy, I no longer have the decision making capacity within my ability. All my decisions are being taken by the children, right? Control, I don't have control over my life, what treatment I have to take. All these decisions are being taken by the people around us. Dignity, see, I am a file number, I am a bed number right now. Functioning, I might be a functioning member, but no longer I am. All these are losses, right? And all these will what you say will come up with the similar emotion that we have when we lose someone. Right? Next slide. So, grief is a total human experience. Grief can be experienced physically, cognitively, spiritually, emotionally, and socially. How do we experience grief physically? Any chat box? You can use chat box. How do we feel emotions, grief physically? How do we feel grief physically? See, personally, we might have gone through grief, right? So, crying, isolation after the physical, cry, wail, shout. Thank you so much, Dr. Somadatta. Crying, right? Other way of physical manifestation of grief. Have you ever palpitations? Thank you so much, Lataji. Thank you so much, Dr. Abhishek. Headache. Thank you, Dr. Kalyani. Headache, palpitations. See, have you felt something choking your throat? You know, there is something that is holding on to your throat, and you don't know what that feels, and there is a sudden heaviness in your chest and heart. Fainting. Thank you, Dr. Nafisa. See, all these are physical symptoms, physical manifestation of grief. We have headache. We feel like fainting. See, there are days when you don't feel like getting up from bed. That level of physical fatigue you go through, and there is something in your throat that is choking you. You're not able to breathe. Exactly, Dr. Soma. Thank you so much. Breathlessness, right? Sleeplessness is there. So my appetite might be poor. So cognitively, how it is going to affect grief? How does it affect cognitively? See, I won't be able to think properly. My attention, I don't have proper attention. My attention is divided. I am not able to focus. I'm not able to concentrate. My decision making is poor. My problem solving solving is poor. Thank you, Dr. Kalyan. Exactly. So that's the way how grief affects us cognitively. Spiritually, see, I don't have hope. I'm hopeless. I don't have anything to look forward to. I have lost complete purpose. I have lost complete faith. Emotionally, I'll cry. I might have anger in me. I'll cry. I might burst out, I might shout. These are the ways in which emotionally grief manifests. Socially, I might self-isolate. I won't talk to my friends. I won't talk to my family members. Maybe if I have a good social support, and if I have good social support and I'm okay for having social support, maybe I'll go through grief I might cope with the loss in a better way also, right? So grief is a complete experience. It's physical, it's cognitive, it's spiritual, it's emotional, and it's social. Right. So the stages of grief, as explained by Elizabeth Kubler-Ross. So I think you might be familiar with this. First, we go through denial and isolation, but she mentioned this in a linear form. Okay. So denial and isolation, from that to anger, depression, bargaining, and acceptance. But it doesn't usually happen in a linear form. It can go in either form. Yeah, I can be in denial today. Maybe I'll accept the fact that I'm bed bound tomorrow, or I'm wheelchair bound tomorrow. Maybe again I'll come back to denial. I might be angry. It could be any way else. That's why the arrows are given in a very zigzag way. It's not linear, and you can even fluctuate in between, right? So, but the stages are, it could be denial, it could be anger, depression, bargaining, acceptance. And usually the last stage is acceptance. Maybe even if I accepted the fact that maybe after 2 days I'll go back again to denial. Maybe I'll have again faith in God. Again, I'll have that, okay, there might be some miracle that is going to happen and I'll be over this, right? So it is not usually in a linear motion, and it can go in either way, okay? So this stages was explained by Elizabeth Kubler-Ross. So I'm moving on to certain types of grief. Anticipatory grief is something that is about to happen. The anticipation of the uncertainty, the fear of the uncertain is usually comes under anticipatory grief. And then there is complicated grief. Usually grief lasts, there is no specific time for grief, and for each person it differs. I might take 2 weeks to come over the loss of my father. Maybe there is another person who might even take a year or more to come out of grief. And there are people who never come out of grief, and these are called as complicated grief, and they might need clinical expertise, or they might need a psychiatrist or a psychologist on board to help them cope with the grief, right? So see, for a fact, you have to know that grief is going to be there with you continuously. It's not going to get over entirely. Okay. See, my father passed away does not mean that he is no longer my father. He still will continue to be my father, right? And the memories that are attached to him, unless and until I have amnesia, Alzheimer's or something, I'm still going to have the memory. So every time I might think of him, I might have this grief spikes. It's called as grief spikes. This comes okay, my spouse passed away, right? So every time every time it's anniversary date, I will have grief spikes. I will think of my spouse, right? That is called as grief spike. So grief is always going to be there, but you grow around grief. You need to understand that grief is always going to be there, but you grow around grief. And then there is disenfranchised grief. Disenfranchised grief means the grief, a society does not allow this kinds of grief. For example, if a person has died of overdose or after drug abuse, you have seen patients or society say, he brought this upon himself. Why are we grieving for him? He brought this upon himself, right? So no need to cry. And if a pet has passed away, people usually ask, it's after all, it's just a pet, right? Why are you crying so much? Why are you grieving so much? But for that person, that pet might have been as important as a person. So this enfranchised grief is those grief in which the society does not accept you to grieve, right? A few examples are, as I said, if a person commits suicide, usually say, he or she bought this on himself or herself, and why are you crying? Mostly anger nowadays with patient relatives cannot. Thank you, Dr. Kalyani. Right. Next type of grief is yeah. And what happens if this grief is not correctly channelized? We take up self-sabotage behaviors. For example, I won't eat anything, I won't sleep, I'll have suicidal ideation, suicidal attempts will be there, serious psychosomatic issues might be coming up. And sorry, there's this technical issues.
Rajika, just a heads up to say that it's 3:10 right now.
Yeah, sure. I'll just wind up. Right. I'll just wind up in a few minutes, right? So, and then we have bereavement that usually follows a loss, a period of intense suffering. So a death has happened, and the time that follows is called as bereavement period. And what happens in the bereavement period is that there is this immediate loss of the person is there, and along with the immediate loss of the person, we have secondary losses, and then further losses are there. There are a few stages of bereavement. Next slide. Next slide. Next. Okay, there are a few stages in bereavement. So initial assessment is taken. We'll assess for suicidal risk or anything like that. Imminent death, that we know that the condition is deteriorating. The condition is deteriorating. There is only a few days left. So we'll inform the family members. We'll make them prepare. We'll assess for suicidal risk or any other risk behaviors. And then there is day of the death, when actually the aspiration, everything kind of takes up, gasping takes up, and we know that death is going to happen, and death happens. That is a day of the death. And 2 weeks after that, we usually take a telephone follow-up to know that whether how they are coping up with the loss. And then after 1 month, we usually again have a review call, and we assess their grief, how they are grieving, whether they have coped up, whether they are, if at all there is any support system we need to do. So there are certain do's and don'ts. We never say call me something if you need to a bereaved person. Okay, call me anything if you need. We have to be very specific. We need to keep boundaries. What we usually see after death has happened, that in order to say something, we might blurt out something inappropriate. So it's not necessary that you have to say something. The only presence can also mean a lot. So these are some don'ts and do's. The presentations will be shared so that if at all there is any other doubt in the presentations, you can put up in the chat WhatsApp group so that they'll reach out to me, right? Any doubt in this area? I know that I just rushed upon the grief and bereavement part, but right. Any doubts in the psychosocial part or the bereavement part, or else we can move to this presentation.
Thank you so much, Rajika. Participants, if you have any doubts, please post in the chat box. Meanwhile, we can have Dr. Dilip presenting the case. I welcome you, Dr. Dilip Pawar, for the case presentation, and it is over to you.
Dr. Dilip,
are you there?
Yes, can you all hear me?
Yes, doctor. Please
Yeah.
proceed.
So, good afternoon, everyone, and thanks for this opportunity. Myself, Dr. Dilip Pawar. So, today I'm going to present, just hold on. Today I'm going to present this case on non-small cell lung cancer, NSCLC. This is a 51-year-old male. The patient came with the complaint of with severe pain in chest and discomfort. So this was the immediate complaint, which was for last 1 day. Then he had a pain in the abdomen and pain in the back. So pain in the back was going on and off for last almost 1 to 2 years. A pain in of the abdomen started a few weeks back, and he was unable to walk without support. The history was for only 1 week. On and off, he had a headache, but trouble in breathing was there for some time. It was more than 2 years. Then hoarseness of voice was recently there, and loss of appetite was there on and off, but it has increased in last 3 months time. And then there is a weight of loss for no actual reason they could figure out. And on and off fatigue was always there, which has increased in last 1 month. So this was a mixed complaint what he presented with. Next slide, please. The past medical history, he had asthma and breathlessness in last 2 3 years, and that was again confusing for the patient. So he said that he has been on and off taking treatment for breathlessness. What was more important, that he had a history of smoking at least one packet of cigarettes for almost 10 years, and he claimed that only few weeks back he has left it. He had on and off cough going on. He has hypertension since last 5 years and is on treatment. And this weight loss and weakness was there for 3 months, which we just saw. What was more important about his lifestyle? Because he has erratic food habits, and there is no family history, which is remarkable. Next slide, please. So blood pressure was slightly raised, probably though he was on treatment, possibly because of the stress. Had body temperatures on normal pulse rate. That time we had a moderate to severe chest pain in the abdomen. The systemic and local exam showed that palpated 2 centimeter of supraclavian lymph node, decreased breath sounds on the right side of the lung base. He has mild hepatomegaly, and he has been completing difficulty in lifting the right hand. Next. The PET scan showed that right lower lobe mass, which is suspicious of primary lung cancer, and there is small pleural effusion, as well as there is involvement of several mediastinal lymph nodes with metastasis in liver and also in the thoracic spines. So, which probably was a reason that he was finding difficulty.
Dr. Dilip?
Dr. Dilip?
Yeah, next please. Yeah. So the patient says he stays in a village and has stays along with wife and 2 children, aged 18 and 14 years, and they are taking education, and is the only earning member in the house. What is more important, the patient works as a salesman in a private organization, and due to his job, he keeps traveling and has constant stress of the sales pressures. And he says that due to it, he developed the habit of smoking and never did a regular health checkup. Though he has small insurance, but doesn't have sufficient finances to cover the entire treatment. Since they do not have a big medical facility in their village, to the city to take advice and treatment. He looks very depressed and blames himself for, I think so, it is because of his bad habits and this thing, is suffering. So patient is worried about the children education and their future if something happens to him, because he doesn't have huge finances which can take care of their children and family. Patient is definitely worried about the outcome of the disease and gets depressed and do not wish to continue the treatment. If he thinks that because it is meds, so probably the life is over for him, or is a short duration of life. Next. So chemotherapy was started with paclitaxel 200 milligram per meter square along with carboplatin. and plus bevacizumab added. So this was planned initially for 4 months with the intention that he might get this thing, and the intention was that then he could have been continued on the maintenance therapy after the 4 weeks, after 4 months of the initial treatment. For pain management, he was started on tramadol, 100 milligram 3 times a day with as well as paracetamol 650. When there was no relief, then the patient was started with morphine 10 milligram 3 times a day. The protein supplement was started because of his erratic lifestyle, and we supported with the organization who was providing free protein supplement. For vomiting, ondansetron 4 milligram was given 3 times. He continued with the antihypertensive treatment with losartan 50 milligram once a day and amlodipine 10 milligram once a day. Amitriptyline 25 milligram at night was started. Laxative Dufalac was started, 2 TSP. Then he was also referred to dietitian because of his erratic, so that he could continue with the high protein diet along with the supplement. And because of his lot of concerns and he was depressed, he was also referred to a psychologist for counseling. Next, please. The prognosis of the disease doesn't look good. Weakness in walking is probably because of metastasis is becoming challenging. As we discussed, the patient is depressed and blames himself for the disease. We need to take care of his psychological issues. And we think that compliance might be issue, so he will constantly counseling for the same. Next, please. In summary, a 51-year-old male with a past history of smoking, diagnosed with NSCLC with metastasis in liver and vertebra with involvement of the mediastinal lymph nodes, is a known case of hypertension with erratic food habit and stressful job which continues. Patient has started with the chemotherapy and pain management. Patient is depressed and needs counseling and psychotherapy. Next. So we need to discuss the importance and role of psychological counselors to overcome, which we find many times a bit challenging. We don't get good counselors, especially in villages or even tied to cities. We have only good main cities, so this is always a challenge. He needs to overcome his depression and insecurity. We need to also check the role of support groups in such cases, how they can help, and how can the patient be motivated to continue the treatment, and what can be done to improve his quality of life, and what can be done apart from this as early detection of cancer. As we see that many patients, what comes to our clinic, and when we do check this kind of patient, the statistics says the most of these patients, more than 80% always come at advanced stage. So that's a big challenge for us as a society and as a country. Next. I think so. There was one more slide where we wanted to discuss some of the things. Possibly there's one more slide, I think so. Dorga slipped. So we wanted to discuss as a psychosocial issue. When we see the India is a country where we have the maximum cases which are related to tobacco, smoking, pan para, gutka, those things are there in our lifestyle, and people take this as a lifestyle. And how we as a medical team and faculty, what can be done so that we can help to have at least early diagnosis, and what can be done as a prevention. And last point, as we see, which is also a big issue, that many of the big stars, film personalities, and other people, which are big personalities, openly advertise on the TVs and all about this eating tobaccos and pan paras and this thing. So which have a huge impact on young minds. So what can be done? This is a burning issue, and how we can take care of. With that, I end my presentation. Thank you so much.
Thank you so much, Dr. Dilip. So the one question that you have put up is how to early detect or how we can prevent this. Obviously, awareness is one thing that we can do. As you know that awareness has increased in the recent times, awareness regarding the use of tobacco, the effect of tobacco, and but I know that all these, irrespective of all these, people still continue to abuse drugs in all forms. But awareness is one thing. Maybe we should start very young, starting from the schools to the volunteers, the support groups in the neighborhood. That is one thing that we can do, at least from our side, that can be done. And the use of all these things in the from in a multi-stars level, I don't know to what extent. It's a case of concern. Thank you so much for putting that up. And I think it has been in discussion for about a while in the social media as well. They are promoting all these things, and children, especially children, are getting influenced by these.
Yeah.
Yes.
So I feel very sad when I see these stars. So I was taking one of these lectures on prevention. So in that forum, I told that I'm traveling all the way, giving this lecture which is free, and I want to promote stop smoking, stop tobacco, stop pan para, gutka, and other things. And other hand, we have these big stars, big personalities, sports personalities, and they're getting paid huge amount to promote something which is bad for health. So this is paradox of life. But I said people might think what individual can make a difference. But I think the other way, even if we start as a one person, even each one of us start deciding and we start putting up in social media and that these are the bad habits, these are things you'll be concerned. And one point you rightly said that it should not be started at the age in the adolescence or the grown up people. But you rightly said we should start at school level. And once this impact is there in the children, I think so this will have a huge impact on the society. That's what I feel.
Exactly. And in recent times, I think the use amongst the stars has also reduced when compared to the previous time, I think, because of this sudden increase. And I'll just check upon a few other discussion points that you have mentioned, the role of psychological counselors. See, I do understand that if the patient is living inside a village, it is it's not possible it's not possible to have a proper expertise in that area. So we might need to equip the volunteers at least to an extent, or the nearby people. We might need to spread awareness among. See, we have a lot of volunteer courses where we prepare volunteers who are willing to help. See, it may not be a completely professional help that they are doing. At least they will be there to look out for risk factors. If at all there is a suicidal ideation, if at all there is something, there will be at least people around those family or around that patient to look out for the risk factors, and they will at least connect with the rightful people.
Yeah,
See,
I fully agree. Yeah, and our association, what we are targeting, that we are targeting two ways purpose. We are training these local villagers. At least after 12th, we are training them, giving some kind of assistant nursing kind of course or help. So at least these people are locally available. So at least initial point of contact, at least they can help them.
Exactly. That is one thing that we can do. Obviously, it won't be a completely professional help that they might be doing. At least they might be able to channelize the patients to the expertise or the people who are in profession, right? So that
Yeah.
is one thing. Role of support group, again, it's a similar thing. How can the patient be motivated? As counseling sessions has to be continued. We might need to take assessment. The psychologist will take an assessment on depression or anxiety. If at all it is in a clinical level, we might need psychiatrists on board. At least start off with a mild antidepressant, so that at least the patient will be motivated to. But this all comes after the assessment. There are a lot of assessment tools that are there, which we usually use to assess if the patient is having a clinical level depression or a major depressive or anything that is in a clinical level. We might need a psychiatrist on board. See, I can understand that there may not be a psychiatrist on board or in a team of palliative setting. At least we need a psychiatrist on call if at all medicines has to be prescribed. The next question is, what can be done to improve his quality of life? See, he was a breadwinner and now he is completely bed bound. Okay, so there is no other breadwinner, and he has two children, right? I think a few messages in the chat box as well. We might need to rehabilitate the caregiver, that is his wife, so that the family will move on. Something has to be done on that level, so that they will be another breadwinner. There will be another income that is coming up in the family. Can I see the messages?
Yes. So Dr. Vincent is saying that's a problem that is often encountered in smokers not realizing the dangers of smoking. Yes. At this time, it is important to educate the patient's wife about the patient's condition and the importance of support from his wife and their two children. Family is the biggest source of encouragement for this patient. Yes.
Exactly, Dr. Wilson. As we said, we might need to motivate the wife. We might need to make her independent, so that the life can move on, as well as children's education has to be taken care of. That are other psychosocial aspects that can be done here, other than the curative aspect is. See, Dr. Rajagopal sir always says that, most of the time patients come here from regional cancer center saying that, they just left us by saying that there is nothing more that we can do. But there is always something that we can do. This is what Dr. Rajagopal sir always says. There is always something that is. See, it's not mandatory that it has to be a curative aspect. It could be something more than the curative aspects. It could be, as I mentioned, it could be education support. It could be vocational rehabilitating the wife. So it could go beyond the curative aspects or symptom management. So we might need to think broader in order to support.
Yeah, I fully agree, and I always tell patients, there's never an end. You can always, and I always tell, though the time is limited, the happiness should not be limited, and we should all try to see and not treat patient as a individual entity, but we has to have a holistic approach, and we have to see the family and our society as a whole, what impact it will have in the family, what impact it has on the society, and will try to support in all the possible ways, not only limiting ourselves for the patient. So we should also do a lot of things to the caregiver. And if possible, we should also connect the caregiver to the support group so that they can generate some employment and those kind of things. Also, we should go over and look all those things.
Exactly. With time's up,
Yeah.
One thing to add on which Dr. Dilip was asking about, regarding the early of smoking and all of that. So for that, I would just like to say, previously the Institute of, the NICPR, the National Institute for Cancer Prevention and Research, they were previously running an online course for doctors, especially where they train us on how to assess such patients. That is because mostly we are seeing oral carcinoma, the breast carcinoma, as well as cervical cancer. These are the most common ones. So they usually used to conduct an online cancer screening training program for medical officers, which was like somewhere around 2 months program where the assessments and all of it we discussed, how you go about. Mostly they concentrate on the smokeless tobacco aspect also. In 2019, I remember that I had done this from the ICMR NACPR wing, and I'm not sure if this is available right now, but you can just Google and see if that's available. I would suggest that if anybody is interested to know more about it, please do this program because it was very, very enriching for me to learn a lot from them. And it basically talks about tobacco control and smokeless tobacco, the oral cancers, which are very common, the breast cancer and cervical cancer, which is very common and can be assessed very much earlier and can be treated because we know that it is a curable type of cancer if you arrive at diagnosis earlier. So I just wanted, all of a sudden when Dr. Dilip was talking about it, I just remembered this many years back I had done this, and I hope if it is still there, I would want all of you to check if you are really interested. Thank you.
So anything else? And guilt is also one thing that I think is mentioned in the slide. People who use substance abuse and all, they have a lot of guilt, which we might have to do a lot of counseling sessions for them because they feel themselves responsible. They blame themselves and even commit suicide for doing so. And also that is one area, one vulnerability area that we might have to look upon, right? So any other queries, if at all there are any other queries and all, please put up in the WhatsApp group so that that could be considered and addressed, right? Anything else? So shall we wind up, Dr. Nadia?
Yes. Thank you so much.
Thank you.
So much, participants, for being very interactive, posting your comments and chat. And I wholeheartedly thank Rajika once again for taking up this session, making it more interactive. Thank you so much, Rajika, for joining us. And thank you, Dr. Dilip, because I know there were certain issues that you had. You were not available for the presentation, but I actually wanted to take up this case because it was really good. So thank you so much for bringing such a wonderful case presentation, Dr. Dilip. And thank you, everyone.
Yeah.
Thank you.
Thank you so much. Thank you so much, all. Thank you so much. Bye-bye. Thank you.
Thank you, Ms. Rajika and Dr. Hashmit for the wonderful and interactive session. Thank you all for the active participation. As always, the session is enriched with much of knowledge and insights about psychosocial issues. We are looking forward to see you on the next session. Thank you all.